Dr. Matern will answer some questions as well as moderate a discussion around the state's recent statistics, as well as a discussion around where we should be heading and how we can help states implement the newborn screen. So I'll just kind of call off who we're going to be seeing up here. Tracy Klug, manager of the newborn screen unit within the Missouri State Public Health Laboratory. Dr. Joe Orsini, Deputy Director of the New York Newborn Screen Program. Darren Sevier, Public Health Laboratory Scientist Supervisor for the Molecular Chemistry Section of Kentucky Newborn Screen Laboratory. Sharon Leonard, Supervisor of the Newborn Screen Clinical Follow-Up Program in the Ohio Department of Health. Gwendolyn McKee, Newborn Screen Data Entry Lab Manager for Tennessee Department of Health. Dr. Barbara Burton, Professor of Pediatrics at Northwestern University, Feinberg School of Medicine, Division of Genetics, Birth Defects, and Metabolism at Lurie Children's Hospital of Chicago. Barb Lesko, Lab Manager for the Indiana Newborn Screening Laboratory. Dr. Taraka Danti, the CLIA CLIA Laboratory Director and Director of Laboratory Services in Pittsburgh, Pennsylvania. And Angela Wittenauer, Nurse Practitioner at Emory University in Atlanta, Georgia, and Director of the Newborn Screen Follow-Up Program. Beth Baer currently works for the South Carolina Department of Health and Environmental Control Public Health Laboratory in Columbia, South Carolina. I think I got everybody. Yes?
You may have more than we have.
All right, well, those are some of the people invited, and take it away, Dr. Matern.
Yeah, thanks for the panel for being willing to participate in this. I think I would like to, since your names were mentioned, but maybe not everyone knows who everyone is, maybe we start with Dr. Wittenauer, Angela Wittenauer, to introduce yourself and where you're from.
I'm a nurse practitioner over at Emory. I'm a nurse practitioner over at Emory University. So I spend a small amount of my time seeing families with inborn errors of metabolism, but I spend the bulk of my time as the director of newborn screening follow-up for the state of Georgia. Emory does that under contract with the state.
Good morning, everyone. I'm Joe Orsini, I guess the culprit from New York State that got this going.
Hello, I'm Sharon Leonard from Ohio Newborn Screening Program.
I'm Tracy Klug. I am the director of the Missouri Newborn Screening Program.
I'm Barb Lesko. I am the manager of the Indiana Newborn Screening Program.
I'm Gwendolyn McKee. I'm the manager of a mass spec LD second-tier testing, data entry and accessioning at Tennessee.
Hello, I'm Taraka Danti. I'm the lab director for Relative Omics at Pittsburgh. We perform newborn screening for Pennsylvania as well as a few other states.
I'm Darren Sevier. I'm the supervisor of the molecular clinic at Molecular Chemistry Section at the Kentucky Newborn Screening Lab.
Hi, good morning. I'm Beth Baer. I'm the director of chemistry and newborn screening at the South Carolina Public Health Lab.
Thank you very much. You could keep it for now.
Okay. I'm not sure I belong here, though, because I have more questions than answers after screening for Crave for a year.
Do you want to start us off with a question?
Well, I'll let someone else start. But
okay. So were there any questions regarding what I said? What? Mike.
Are there any clinically documented cases of late onset Krabbe disease where we know cytosine was less than 2 nanomolar?
There is that famous case.
Yeah, the famous case. Other than that, I think you might have misspoken. You said some false positive, false negative. So Will we have any false negatives for late onset if states go for 2 nanomolar or higher? I think very few, if any, right? False negatives. Or we don't know.
I think I don't think we have cases with less than 2 that develop symptoms.
Right. So I just want to make that clear, because it wasn't in your talk. So that, yeah. So and you'll get rid of the vast majority of false positives if you have cyclosine of 2 or higher. I think Illinois was down to what, 20 or something like that, or was that?
Well, Illinois uses cutoff of 1.5 at this point. They had it at 1.08 and increased it, and that reduced the false positives dramatically. So yes.
And presumably everybody that goes down to 2 nanomolar would do genotype at some point, if it wasn't above 10, right? If it's above 10, it's an emergency. If it's 2 to 10, probably most places will do genotype, right? And we'll learn more.
Well, you would still follow up by checking cyclosine in another specimen and GALC activity in leukocytes, and you would do the genotype. And then you take it from there.
I have a comment on Dr. Gelb's question because in South Carolina, we use GGC for our cyclosine testing. And we had the misfortune of identifying a baby during our validation that might have late onset. And Dr. Kurtzberg, you know about this case. And that cyclosine was less than 2. And we recently had another one that's less than 2. I think GGC's cutoff for cyclosine is 1 nanomolar. And so we've had 2 now that are being followed. And I think the genetics on the most recent baby were actually discussed during one of Dr. Kurtzberg's most recent calls that we had. So it's a very, very complicated disease. The genetics are extremely complicated, but I do think people need to look very closely at that cyclosine cutoff, because if those babies may end up with late onset Krabbe disease.
Yes, again, as I said, when you apply a cutoff of 10, you will certainly miss cases. If you apply a cutoff of 2, you may still miss these very rare cases. Now, I hope that that is rare in South Carolina too. And as far as I know, this patient is asymptomatic, so we don't really know what's going to happen.
Yeah, I think they're both asymptomatic.
Yeah. So now you have this family going through the monitoring for ever until they make a decision. This kid does have Krabbe disease, and now we're at a point where we need a transplant. But again, if that doesn't happen within the next 10 years, my argument is that you would identify this kid otherwise, and until that time is just going to have a typical life that is not disrupted by frequent visits to doctors who talk about stuff that no one wants to hear about. But Dr. Kurtzberg.
For me, it raises a different question, not that I'm not taking seriously the one you raised, but how well are these assays standardized between laboratories, and what is the range of confidence between a given value?
So we have tried to standardize, harmonize as good as we can by using all presumably the same reagents and the same calibrators. We published that. Mike was the driving force behind that several years ago, where all the laboratories at the time that were participating or measuring cyclosine compared notes, and then by using the calibrators, we're able to bring it very close. The problem is that, yes, at the low end of the normal ranges, it becomes tricky.
So
one was 1.63. I think that was the most recent one. The other one, I think, may have been less than that. I wish I could tell you. I can find out. I have to get the
It
report.
wasn't straightforward, like always. Yeah. But my question is still today, like Revity's cutoff is 1.5, Greenwood's cutoff is 1, I guess. And is there a way today to redo that comparative study you're talking?
Well, we do inter-lab comparisons.
And all
so,
those labs
and
participate.
there, I think all of us participate in it. The thing is though, that there is no laboratory test, quantitative laboratory test for anything where you would get the same result. You can do cholesterol, on yourself, send it to 5 labs that all use maybe even the same FDA approved kit, and you will get a different number. The problem we have with Krabbe disease and newborn screening, you have an asymptomatic baby, and you are now measuring something which at nanomole levels, which is just tough. And again, this is population newborn screening. We have to make a decision. What is the target of screening? And at least you have now the secretary said, basically the target or the core condition is infantile Krabbe disease with a cutoff of 10. Now, if Kentucky told me we want to follow the recommendation, then I would stop reporting anything between 2 and 10. I would increase for Kentucky the cutoff of 10, would find a way that I never have to see an 8 because I don't want to see it, know about it, and report it as normal. But I would find a way to do that. It's up to the states to decide what you want to do. You have to involve your advisory committee, you have to talk about it, and you have to weigh what you want. You want all of Krabbe disease, but then you have false positive, and you have a lot of cases that are in this, maybe Krabbe at some point. But it's not going to be in the next few years or 10 years, with very few exceptions that we also published because we thought we had to be very transparent when it comes to the RUSP nomination. So it is difficult, but it is a weighing of what do you really want when you screen a whole population. Yep.
I just wanted to mention, because this is a hot topic in ALD right now, because we're getting many, many more questionable cases, and I'm very pro newborn screening, don't get me wrong, but it brings up even more questions like family planning. Should people be going through PGD stuff if they want additional children? Do the numbers change with time? That's something I don't think we really knew. And now we have kids that have not an insignificant, but a handful where newborn screen is positive. We decide to recheck them. Now it's normal. So I think when it goes bigger, it's important just to think about that it does have more far-reaching questions that come up.
I certainly agree, and thank you for mentioning that there are other conditions that have the same issue. And now we're screening for what is now 38 core conditions. So all of these talk about for Krabbe disease really applies for the majority of them as well, where we have to theoretically make these decisions. We just don't do it because those conditions are not like Krabbe disease where you have to do a transplant in 6 weeks. But that's a problem in newborn screening ever since. And I think, as you can see, and it started with adding spinal muscular atrophy to the RUSP, where the secretary said you're screening for SMA, but only for the cases that are homozygous for a specific pathogenic variant that we knew very well what it meant. Which brings another set of issues about fairness and all these kind of things. But these are the decisions that have to be made. And that's why I say they have to be transparent, and you have to put it on your website, what you're actually screening for, that everyone who wants to know can figure this one out. Okay. Yes, go for it.
I wanted to just ask, even though we're trying to set the cutoff for 16 at 10, are there any cases where there's been an infantile at less than 10? And I ask that because my counsel is just a little concerned that there may have been one, and they are a little antsy about trying to set a cutoff at cyclocine at 10. So
Yeah, there's this famous Dr. Thompson Stone case. Do you want to say something to that?
Yeah, so this was, I think, an important case to highlight and to understand, but also to not halt, appropriate newborn screen strategies because of. So there was just, real quick, a patient who had a cyclocine that was kind of like on the borderline of 2.0, with multiple tests that were slightly below or slightly at or above 2.0, who ended up having what we felt was the onset of Krabbe disease around 6 months, 6 to 8 months of age. We became involved after the onset of symptoms, so could not refer for transplant at that time. This patient did end up passing away around 2 years old. We checked MRI scan, and I'm trying to remember about nerve conductions. I can't remember that, but MRI scan showed findings of demyelination that was likely consistent with Krabbe disease. Also had exome sequencing that did not show any other genetic differences that would account for the symptoms. So it's sort of that asterisk case that it's not entirely clear why that happened, but the point of that case in my mind, and the reason that we published it is because we wanted to remind primarily patient care providers that you have to pay attention to the patient. And the numbers are really important. If you have a patient in front of you and they have symptoms they're developing, it's important to pay attention to that patient and think about what that patient needs based on their clinical symptoms. So there was that patient. We did not find a specific other cause for their condition, although it is possible that there was something different about that patient, or something that we just couldn't identify with their genetic testing.
I don't understand where this conversation is going. So you don't want to miss a single one in South Carolina and Tennessee, but the alternative is worse, right? So I tell your health board, what is the solution? They don't want to miss one. Well, they're going to miss one. I mean, when we start doing DNA, they're going to miss so many things. It's a new paradigm. We're not going to catch every single case, and nor are you expected to, and legally you don't have to. So why are we talking about the problem of missing one when we catch 20? And then you're going to break the system with false positives. I don't understand where you're going with this.
Well, I don't think Gwen is going there. But I just a second. I just want to put into perspective. And Joe, how many babies were screened now in New York? About 4 million babies were screened in New York, and there's one such case. So it appears to be extremely rare. And there's all kinds of screening going on. Some of you may have had a mammogram, colon cancer screens. Every time you get a result, it says, looks fine, but always look for something that's unusual.
So I'm Jen, I'm from Chicago. We have had lots of possible late onset, but I want to quibble with the idea of false positives. They're not necessarily false positives. They're just not infantile or late infantile Krabbe disease. But many of these identified may go on to develop late onset disease.
Yes. So again, it depends
I would be fine with not finding those, but I don't necessarily think they're false positives.
What to me are false positives are cases that are carriers.
Right. So some of them might. Yes, some of
those
them
should
might
not
be.
be reported.
Correct.
Because
some of them may be late onset phenotypes that have not yet declared themselves because we don't have enough data yet.
Yeah.
I would be fine with not finding those.
Yeah.
What if there was money and you screened 100 million 30-year-olds who are healthy in the US? What do you think you'd find?
Sorry.
What if there was money to screen 100 million 30-year-olds, if there are 100 million 30-year-olds in the US? What do you think you'd find? Yeah, well, I'm just related to Krabbe. Well, I know, but I mean,
For Krabbe disease, if you basically did the newborn screen on 3-year-olds.
Yeah, 30-year-old. 30.
Yeah. Yeah, you will find similar results as a newborn screening.
And the data is on the web, so you can look how many, and most of these people are adults. So we have the data. Not 30 million, 100, what did you say, 30 million? We've sequenced 4 million genomes. It's available.
So
Okay.
I have a comment. I just want to respond to Dr. Gelb's comment on missing one baby. You know, in South Carolina, the reason why we added Krabbe disease is because the state legislature mandated it because of one baby in the state who was identified, and we're getting ready to add Fabry disease because of one person. It's not even a newborn disorder. So people have to understand that there's a lot of politics involved, and missing that one baby, it could determine a lot of things.
I agree there's a lot of politics in it. But I also have, in my experience, when you talk to the people who have these concerns and you explain to them the bigger picture, they don't get it.
There's no explaining.
I don't know what to do about that problem if people are ignorant. I don't know what to do.
Well, again, you can point to the RUSP recommendation, the way it's put on RUSP, and say, well, actually, we're already finding more than we should or have to based on the federal recommendation. Do you have an advisory group in South Carolina?
Yes.
And that includes some geneticists and neurologists and people of understanding.
Yeah. Yes, sir.
I still can't believe we cannot convince them that there is a middle ground.
No, not when it comes to newborn screening. It's a very passionate topic.
So are we. Okay, so one of the issues that states may encounter is, especially the ones that started screening already, is the advisory committees, where you have people who just are super anxious that they might miss something, even if it doesn't have any symptom for years to come. Okay, that's for the states that currently screen. Now, states that are not currently screened, is anyone here who can speak to whether this was going to be a problem for you going forward, or can one introduce the concept of newborn screening for Krabbe disease under the premise that you have to make a choice, especially given that the secretary said it should be with a cutoff of 10 for psychosine, which basically eliminates everything that is not infantile Krabbe disease. Do we have a state that's not screening here? I don't think so.
So Ohio originally, so Krabbe was added by our legislature. And in the original law, it said we were not allowed to do any form of second tier testing. It also allows parents to refuse screening for Krabbe only, which is very interesting in our data system. So we have, the laboratory has wanted to add psychosine since the testing became available, because we have a huge false positive rate. And we have gotten grant funding this year. Well, we got it last year, but it's being used this year to hopefully implement GAG and psychosine second tier testing. We have gotten our law changed so we can now do second tier testing. So we are meeting, our advisory council's meeting this Friday, and on the agenda is the discussion of where we should be setting our cutoff. So we have not yet had that discussion, but our advisory council will be who primarily advises us, gives us the recommendation of where to put our cutoffs. Dr. Kurtzberg is going to present at that meeting, so that they will have an expert to ask all the questions to, choose whether we set it at 10 or we set it below 10.
Thank you.
So I think that gets to an interesting question that we can maybe go through our panel members, which is really, are you thinking of what is your current testing strategy, and are you thinking of making any changes based on the RUSP approval to the psychosine cutoff, as well as is there GAL-C sequencing as part of the testing, and any plans to implement or reduce the amount of genetic testing through the newborn screen panels? So we'd love to hear from the different states about that.
Thanks, Rob. So in Georgia, we started our pilot. Dr. Matern gave you a very nice overview of what we do, but we, do the enzyme as part of a 6-plex panel of LSDs and use that data in the CLEAR tool hosted by Mayo that determines which samples are sent off for second tier testing for psychosine. We use Mayo's cutoffs that they publish, which is the 2 and the 10. That was part of our pilot. We had a state-funded pilot that just ended and has rolled right into on our panel permanently. We have decided to stay with the same algorithm for now. We talked about that in our committee. So far we started in September 2021 with the pilot. We have had 1 positive screen using this algorithm, and that was a real infantile onset case. So the numbers have not been a burden. False positives are a huge concern of mine. We have done pilots with inordinate false positive results that are detrimental across the board. So I'm not a fan of that. But we agreed that it was kind of a loosey-goosey decision, but for now, we're just sticking with what we're doing, and decided that we'll just keep monitoring it. If it becomes problematic over time, we may consider changing that position. But for now, it has not been problematic. So we're reporting 2s and 10s with a different strategy for each of those groups.
In New York, I'm pretty certain I won't be able to convince people to move anywhere away from what we're doing as far as the 2 cutoff for psychosine as well. So certain we won't just be screening for infantile cases. We still have some I still have to bring our inherited metabolic disorder group together and really have a firm discussion with them to kind of go through this and see if everybody's in agreement, but I'm pretty sure that's the way it works. Yeah, we'll stick with 2 and 10, the 2 and 10.
I already kind of spoke for Ohio, but I think one other thing that we need to think about in our state is that we report out values. And so even if our advisory council says, we're only going to consider 10 abnormal, we would still be reporting psychosines of 5 and so forth on our newborn screen. And I think there's a whole issue we have to discuss and figure out what we're going to do. I have no idea what our council's going to decide. So I'm just kind of waiting and seeing.
So in Missouri, we implemented Psychosine as our second tier in 2020. And since then, it was a game changer for our referrals. We had been screening since 2012. And we were referring maybe 30 per year. Crab A. And then after we implemented Cyclizine, that average dropped to, I think in the last 2 years, we've referred 3 patients each year. So the Cyclizine has really helped eliminate a lot of the false positives for us. We've had zero Cyclizine levels between 2 and 10. So that's our plan, is that we'll continue to refer anything above 2.
So in Indiana, we have a legislative mandate to screen for crab A. So we're not sure as an advisory group if we can specify that for infantile. So currently, we have a second tier process of sending to Revities for simultaneous cyclizine and 30 kb, acting on the cyclizine alone if needed. We've been screening since July of 2020 and have never detected an infantile. One of the things that, when we got some suggested questions before this meeting, I, went to our care team, and I think they feel obligated to follow up if anything is above the reference range. Revity reference range is 1.5. So the idea of looking at Mayo as a second tier to customize that, should we decide to go to a 10 cyclizine cutoff, is intriguing.
Well, Tennessee currently we do screen for a cutoff of less than 10 for our enzyme, and then we reflex that over to our second tier, which would go to Revity, and then we use Revity's cutoff to determine if we're going to do DNA sequencing. So anything that flags abnormal for the cyclizine at is greater than their cutoff, then it'll reflex. Otherwise, we report it out as WNL. And currently, our council is actually next month we'll be discussing if we want to change the cutoff to greater than 10, just to catch those infantile babies. Since we've been screening since 2017, we have 2 infantile babies that we have reported, and 7 late onsets.
So just to remind you, I'm from Revity Omics. So as a service provider, Revity doesn't have its own cutoff. We follow the states, whoever is our client, their wishes to set up a cutoff. So currently our cutoff is 1.5 nanomolar. And Pennsylvania Advisory Board is meeting sometime soon to discuss whether they would like to change that cutoff. And once they do that, and if other states like Tennessee and Illinois or Indiana wants to change their cutoffs to have a common pattern, then we would love that, and we can change that cutoff. It's not Revity's choice. It's the Pennsylvania Department of Health choice.
I don't believe that. That's the wrong answer. Sorry. I've never heard that before. Okay.
So typically when you develop an assay, and again, a laboratory developed test, it's not an FDA approved kit. So every lab has to develop this method in the laboratory, validate it, establish reference ranges. And so then you have to think there is a reference range, which is basically at least 120 perfect angels that you measure the cyclizine in. And usually, I think in all our labs, probably the 99th percentile is about 1. So if you're an analytical chemist, you will just say, okay, this is where I draw my line, and it's 1. Or you say, I take the mean plus 3 standard deviations, and that is where I draw my line. And that could be another number. As a biochemical geneticist, I'm looking at, okay, this is what the analytical chemistry looks like. And this is how my normals look like. What do my patients look like? And I know that for infantile Krabbe disease, they are 10 or greater. And for the other ones, they're between 2 and 10. Most of them fall in there. Now, The knee-jerk reaction is when you find it or hear of a case that you missed with a cutoff of 2 because it was 1.85. But lots of people would do, okay, now we go to 1.84. So that never happens again. But again, I think when it comes to population screening, you have to look at the bigger picture and all of the babies that would now be picked up or not picked up, but identified as having a value of 1.87. And now you're going to follow them up for Krabbe disease. And probably at this level, you will follow them for their life because they will never develop any symptom, but you don't know because they had an abnormal newborn screening result. And this is where I think, again, there's the analytical chemistry, which tries to be super accurate, which is fine. We need to do this exercise. But then setting a cutoff is a different issue. That is really a clinical issue. What do you want to achieve? So that's basically why Revity, when you tell them we want a cutoff of 2, they will raise their cutoff to 2 and will not report that other stuff anymore.
Okay. In Kentucky, we had a law passed, and the law basically just says that we screen for Krabbe. So as of this moment, well, when the law got passed, there was a very big time crunch, so we didn't have time to bring the test in-house. So as Dr. Matern mentioned, we approached them for contract, which I think at this point still has genetic testing in it, even though
as a third tier.
Yeah, even though it probably is not useful. But contracts being contracts, that's the way they are. But as of like I said, it just says that we do Krabbe testing. It doesn't say that we follow the RUS per every single secretary's recommendation. So we're not planning on changing anything right now. We just let Mayo do Mayo's thing. So we're pretty happy with them.
No comment. South Carolina.
Yeah. So in South Carolina, we're not going to change our algorithm. We work very closely with Greenwood Genetic Center. Their cutoff right now is 1 nanomolar. And Dr. Matern is absolutely right. When we do our validation, you know, as an analytical chemist, I like to set that cutoff, but then we test a lot of known diagnosed cases to really refine that cutoff. And then we also work with our metabolic specialists and they help us with that. But, you know, one thing that folks don't always realize is, you know, we do the GAL-C screening in the lab, and then we send off for cytosine testing, but we still report that GAL-C before we get the cytosine testing back. And I know a lot of people don't like that, but sometimes we're limited by our limb system and the functionality of the limb system we use. And unfortunately, not unfortunately, we're happy with Revity, but we have to either report all or nothing. So we can't hold, you know, we worked with them on this. We can't hold our results to get the cytosine back, but our follow-up team does work with our providers and let them know that they really shouldn't do anything with those abnormal GAL-C until we get the cytosine back. I will say that we recently had a very low enzyme activity GAL-C that came back less than 1 for cytosine, and I did ask GGC to sequence it because I was concerned about it based on discussions with Joe with those really low enzyme activities, and it ended up being the baby was a Krabbe carrier. So I think that 5-year report is going to be really important to take all of this into consideration, especially with all of us now looking at genetic sequencing, because that is the future for our lab.
I have one comment about your report. Have you thought about just putting pending on there, like saying that there was an elevated GAL-C, but not give it a value, or decreased GAL-C and don't give a value, but say that was pending second tier testing, and then modifying it when that second tier testing comes back. We do that with like our methylmalonic acid testing. So yes, we have specimen gate. So we can talk about that later.
Okay, we found one solution. Thank you.
We also do what South Carolina, excuse me, does in where we will the doctor will get the result of the enzyme, the low enzyme, but we also give them the clear, and they really take those two tools and look at them, but they still will have the actual patient come back in for testing before we actually get the cyclosine results. So we kind of have that same algorithm.
Okay, again, I think it's important for the advisory committees to look at that data, how often you report something, what are the primary care providers or the specialists doing with that result? Because my concern, based on what we see, is we still get calc activity in leukocytes, cyclosine red blood cells, molecular testing is being done. And then we say, why did you start this? Well, because the first result was a low calc and I felt I had to do something. And that's just means a family was told there's something wrong. What's wrong? Well, this is Krabbe disease, but let's not talk about it. And guess what? They Googled that, some of them. Okay, thanks for bringing up these questions again. So one of the issues I think that also needs to be addressed is the follow-up. So because infantile Krabbe disease is what in RUSP terms is a critical condition, which means that the screening result should be reported by the 5th day of life, which is a great idea. But it is very difficult, especially when you have a second tier test now included that is not available in every state lab. And so you add already 1 day because you have to do the cyclosine. So one of the things that maybe should be brought back to the advisory committee is in the form of a public comment or whatever, is to say, well, we agree that there are critical conditions, but you also have to look at, okay, there are critical conditions for clinical purposes and not because of a day of life. And so I think for Krabbe disease, it is acceptable as long as you get this kid to the treatment. So that brings the question, can you actually get a baby with infantile Krabbe disease to a bone marrow transplant within 30 to 45 days? And it worked in Kentucky twice, even though it was out of state. The first kid we identified for infantile Krabbe disease in Kentucky, we reported it back to the state, I think on the 7th day of life or 6th day of life. And we heard then, and you guys thought that you have and the University of Kentucky or Louisville or whatever, that they're willing to transplant these kids and they're ready to go. And they said, nope, we're not. And so through friends of friends of friends, this patient ended up still at whatever 4 a.m. On Dr. Kurtzberg's doorstep in the neighboring North Carolina and got a transplant at 24 days. The second case we identified was on New Year's Eve, which complicated things a little bit. And that patient was transplanted on 30 days of life in Pittsburgh. And in Minnesota, after a month, we had a kid with infantile Krabbe disease. And Dr. Orchard, who sits here and who I'm putting on the spot right now, was very concerned when Krabbe was added to get all the approvals to get a baby transplanted so quickly. And so I would like to ask Dr. Orchard to quickly say a word about that case.
Thanks, Dieter. I think some of the big concerns are whether we can get insurance fixed quick enough to be able to do this. And this baby was a Minnesota Medicaid baby, so it we weren't going to be able to get it done unless we admitted the patient. So we admitted her or him and started the evaluations as quickly as we could, and it ended up working out okay. I'm still, maybe we're going to talk about this a little later too, because there's a panel discussion, I think, this afternoon. But if North Dakota and Iowa and South Dakota end up going on, and they have a Medicaid patient there, that's going to be a problem. They can't transplant their own patients. And sometimes it takes months to get Medicaid fixed to be able to treat patients. So whether we can do something prospectively, like your last bullet point here, whether we can do something prospectively so that we don't have to jump through those hurdles when these babies pop up would be really important, because that stuff keeps me up at night, is that we'll find a baby and then we aren't going to be able to get the kid to a treatment center and be able to treat them expediently, because the insurance pieces are going to be a problem. Particularly the Medicaid issues, I think, are going to be of concern.
And I'll just add that thank you for those comments, Dr. Orchard. You're right. We are going to be talking a lot more about that after this panel and a couple other sessions about how we sort of take it from the referral to try to implement quick testing and those conversations. So we can hold a little bit more of that discussion for that session. But I'm curious to know from our panel members, one of the things that's important is the timing of when, especially infantile cases, results are released. So Dieter's mentioning that, it's a critical time. So I'm just wondering from any of the panelists, what you think is sort of possible, or what the standard is for timing of when something like that might be released.
So to Dieter's point, the 5 days of life is a really nice idea. But having said that, we do not report enzyme for Krabbe disease without the second tier test results. It's just, to me, irresponsible. So we don't do that. We wait for the second tier test results and we get those reported out right away. When we brought this up, I brought together our state people, my genetics team, our bone marrow transplant team, our neurology team, all our teams. And I was like, this is what newborn screening is. Here's how it works. Let me introduce you. And it did a certain degree of bossing around on that this isn't your standard clinical care case where you get to lollygag around. This is time sensitive and we have to act quickly, and you need to be able to respond to emails and phone calls and things like that. So we have a strategy where everybody's on email lists. I have everybody's cell phone numbers, and the goal being, if it's a 2 to 10 result, we'll report that on standard business hours kind of strategy. But the folks at Mayo know if it's one of our 10 kiddos, they will call us they will page the folks on call, and we have a written protocol that I've distributed to everybody, so that even if it's Saturday afternoon, we're going to get that kid to the children's hospital. Georgia has we have several children's hospitals, but the main one is in Atlanta. And if you were going to get a transplant like this, you would be coming to Atlanta. So that makes it a little easier. The whole state is on board with that, and makes it a little easier to say, you're going to get that kiddo to Atlanta. And everybody's like, okay, great. So that makes it a little easier. I would say it's a little messy in terms of who's on first, but at the same time, everybody's so attuned to this that I think everybody's on first, which is kind of great. And I feel like our team does a good job of paying attention and responding really quickly. So 5 days of life, whatever. But I would say, probably to Dieter's point, that I think it's more important that whether it's 5 or 6 or 7, the point is to get that kid in-house as quickly as possible and get things rolling, confirming, and working up for a transplant in tandem with confirming your diagnosis and making sure that the family knows what's going on.
So in New York, we're going to, one of the things we do that I think speeds things up a little bit is we get a pretty good idea of if we're going to have a really terrible case or not by looking at all the other enzymes. When we run this test, we run GAL-C with 2 other enzymes initially, and we run a repeat test with 6 enzymes. But if that first test that we get is very low enzyme activity and the other two enzymes are pretty normal. That becomes an emergency send out to Mayo for cyclosine. And if it's really low and those other two are pretty normal, we're starting to see, where is this baby from? Who do we need to call? How are we going to give them a heads up that we think we have one that we're going to be really concerned with and that we're pending cyclosine results on. So that's what we do. And it's kind of, we're basically poised and ready to pull the trigger on that. And then to the other point of the 5 days, I worked with APHL in the newborn screening committee. I'm actually the chair for that. And it's actually a topic where we're going to bring to the ACHDNC group the concept of clinically versus, like there's this critical care. Right now there's a 5 days, which was really meant for if somebody's going to become clinically affected within that 5-day period. In Krabbe, they aren't clinically affected in 5 days, but there's definitely a ticking time bomb. So we're trying to get it treated in a little bit different way so that it will take a little bit of the pressure off the labs. Doesn't mean they shouldn't do it as fast as possible. That's like Angela said, that's the point. But to feel like you missed the 5 days and you were a failure is kind of ridiculous, so it's semantics really. So we're trying to correct that.
I would say if I put a number on it, we are probably reporting Krabbe results usually on the 6th or 7th day of life. It takes, we have overnight courier and everything, but it usually is the 3rd or 4th day of life before we even get the newborn screen. And then the assay, if you're, run it and then confirm it, takes 3 days. So, it's just really hard to see how you can speed that up. The other thing that just to kind of to go on there, we in Ohio do not plan to report out until we have cyclosine back. Once we start doing cyclosine, kind of the same thing. We don't see that there's any benefit to reporting out the GAL-C before we have a cyclosine, just because we've been dealing with false positives for so many years. The other thing I think is really important with reporting out is on our critical cases, we call the specialist before we call the pediatrician, because we just feel that that is the best way to get the pediatrician the support they're going to need to deal with the follow through with talking to the family and getting the referrals set up. We don't know yet.
Can you repeat the question?
So she asked how much time it'll add. So a lot of decisions need to be made. The kind of working hypothesis right now is that we would send the cyclosine after the initial abnormal GAL-C, and then we would be confirming the GAL-C along the same timeline as the cyclosine is being run. But
there's only 99% of the time the second tier comes out the same when it's really low the first time. So it states that are wanting to get a second GAL-C before they do cyclosine, that doesn't make any sense. You should do the cyclosine. It's a good move, Sharon.
Yeah, that was
mostly gonna confirm it,
right. We're trying to figure out what is the best use of time to get these kiddos diagnosed as quickly as possible. So I think that is our plan, but we haven't yet chosen the laboratory we're sending our cyclosines to. So the time factors haven't all been figured out yet.
I would just say in Georgia's perspective, we send out to Mayo and it adds depending on the day of the week, 2 to 3 days. So it's not terrible.
Barbara, Illinois was waiting for the second test, so I think that's a bad move.
So in Missouri, we also send out for cyclizine. I would say our average referral, the baby's 7 to 8 days probably before we can refer. With the addition of cyclizine, although Mayo is very, very fast with that turnaround. It just takes time to ship it and all of that. So we did change our protocol. We were confirming GALC, and GALC is an overnight test. And so it does automatically add up quite a bit of time. And so we, for sure on weekends or on Fridays, we just go ahead and send to cyclizine without confirming. And if we see some that are really scarily low, then we do go ahead and send those without confirming. But for us, GALC is a standalone test, and so we can't really see all the other enzymes like Joe and the mass spec states. And so sometimes we do have just a failure with the GALC enzyme test, and it's just low for for a random lab issue. So some of those cyclizines are kind of unnecessary, but we do feel like it's better to go ahead and preemptively get those tested. So so that's how we do it in Missouri. We do, just not on the fluorescence. We can.
The other enzymes.
We could, yeah. Just sometimes we have like a well failure where there's no enzymatic activity for GALC.
Okay.
Do you know?
That's
yeah.
a separate GALC
Yes.
thing. Okay. Yeah. Okay.
Yeah, so in Indiana, we have a similar approach to New York, where we still repeat everything, but if we have a GALC of 8 or lower, we send that simultaneously and on Fridays as well.
Regarding that, if you do the repeat and it comes back as normal, you can cancel the cyclizine. Then you don't have to pay for it.
What we do is if our GALC is low, we will repeat it, and that usually takes on another day. So we're looking at about 3 to 4 days just to get the GALC. And once we get that, we will send it out, like I said, for the second tier. And we send second tier to Revity, and that takes usually about 2 to 3 days. We'll get our results. It can be 4, but we've usually gotten it back in 2 to 3 days. And if it's abnormal, that's another 5 to 7. And this is also something that once the GALC is abnormal, it is sent to follow-up, and follow-up will work with the providers. And the problems that well, they're not really problems, but that 18-hour incubation really does hold you back, trying to make sure you get that back on in a timely manner and get those results out. But we also, just the actual sample that you're getting, we're not always getting, a lot of sample, and that can also cause a delay because we may have to request another sample. It's not something that happens often, but it can be a challenge because you find you have a low enzyme, but you need to repeat, and you're having to have your follow-up team to see if the physician can get that baby back in so that we can get another sample. So that can bring you up to almost a little over 5 to 7 days.
So for us, for low GALC, we immediately do reflex. We changed our thing because of a couple of instances that involve Dr. Kasberg and Dr. Martin here. One of them I remember is Christmas Eve. So we automatically reflex low GALC to cyclizine.
Yeah, since we are contracted with Mayo, that kind of hampers our ability to report out anything too early, although Mayo is great with their turnaround times. Like normals, we usually get back within 2 days of sending it. So, and we send the specimens to Mayo the same day we receive them. So you're losing a day there because of transit. But as Dr. Matern said, our two positive crab A's have been 6, 7 days. I think one with the second one was closer to 5, wasn't it? No, it's pretty quick. So we just try our best to do what we can. I like Joe's talk about whether or not it's clinically viable or not. It's like, this is not MCAD we're talking about. This is something that is slightly less life-threatening immediately. So that would be a nice distinction there.
Yeah, that's a really good point, Darren. We test for 56 different disorders, and some of them are considered time critical. Obviously Krabbe is time critical to us, but so is MSUD, MCAD, galactosemia. So we really push hard to get our results reported as quickly as possible. We probably have a reporting of 4 days for our samples once they come in. We went to a private dedicated newborn screening courier to improve our turnaround times, and that really improved things a lot. And then the cytosine results get back to us usually 2 to 3 days after sending the sample to GGC.
Thank you very much. So again, I think that's great to hear, Joe, that APHL is kind of addressing this. We certainly don't want to go back in terms of not getting the MCATs out and the galactosemias. But I think as more and more conditions that are different are being added, we just have to be a little bit more nuanced as to what these definitions of critical actually means in real life. One of the things is if you're a newborn screening lab, you really should be a 7 days a week lab because babies are born every day. That's just going to continue, I think. So I think I appreciate all the laboratories that, since the issue of timeliness was raised at the advisory committee, have stepped up to the plate and increased their time of business. Do we have any questions online that we should address?
I was just going to mention, thanks for that segue. Anybody who's joining us virtually, please feel free to type any questions into the chat. We'll try to get to them. Do we have any at this minute? No. So any questions from the audience for our lab personnel about these procedures?
Hi, I'm Dr. Avula. I'm from San Antonio. So I know there has been a lot of discussion about right cutoff for the newborn screen to avoid false positives and not to miss any false negative. But do you guys have any knowledge about what they are using in Europe or Canada or Japan? Because most often, medications or treatments, they are delayed by 2-3 years here in the US. So just to get an idea.
Yeah, we are leading the pack. So there's no other country screening or region for Krabbe disease, as far as I know. I don't think, Mike, that Archimedes is screening for Krabbe. So yeah, so all the knowledge is here. I'm glad that we have someone from Texas. Texas is one of those states that actually screens every baby twice, shortly after birth and then again at 2 weeks. I don't know why. And there are other states that do that as well. And I wonder what those states will do when it comes to Krabbe disease. Will they? Yeah, I have no idea. I never heard anything, and I assume since you're not associated with the screening lab, you may not know. Okay, so you are anticipation. Can't wait for it to start. Okay. Do they use mass spec? Yeah, so they're actually, so I mean, one of the arguments that we made, and specifically when it comes to the first time that Krabbe was declined, when they said, well, can you actually multiplex it? What is the cost of screening? And with Mike's essay, it's a multiplex essay. So, but if you are already screening with tandem mass spec for Pompe, MPS 1, MPS 2, you basically already screened for Krabbe, because I don't think that Revity takes out the Galc reagents out of their kit. So basically all you have to do is change something in your software and ta-da, there's your enzyme activity. So you're already paying for it. Okay.
So because of Ohio's unique refusal policy for Krabbe, and our legal counsel saying if a parent refuses, blocking the results was not an adequate response, we actually have both an assay that runs all three enzymes, and then we can pull out our Krabbe refusal samples. They're marked, they're pulled out before we accession, and then they are run without the GALC enzyme.
No comment. Well, yeah, I think there are these unique places. I wish we didn't have 50 unique places in this country. But it also kind of, again, comes back to the issue of what do we have to do? What do we have to do to help the states? And I think, Angela, if you published your approach of how you actually got all these kits in order to be ready when it happens, I think that's important that you share that information. These things are sometimes difficult to publish, but there's the International Journal of Newborn Screening, and you have an editor sitting next to you, so I'm sure they're willing to consider that. Maybe, Joe, there should be a special issue on preparedness and what can be done, how you can utilize the advisory committees to come up with the protocols to actually allow you to do what you're supposed to do. I mean, we all do this for the kids. We don't do this for politicians unless they have children. We do this for the kids, and I think we have to be the advocates for the children, the healthy ones that we don't want to bother, but then, of course, the ones that we actually want to identify and get to treatment. And there's no politician who wouldn't agree with you as long as you say there's a baby involved. So
other questions from the group? Down there. Oh.
About this debate about the infantile or late onset, obviously, the newborn screening was designed to treat those infantiles and late on infantiles. But the landscape now is changing with the gene therapy coming along and other therapies. So eventually, the late onsets will benefit in some way from the newborn screening. I just want to say that because, and then about the molecular, the genomics and all that, some of the variants we work with Joe and discussing those 1,500, they're not even reported. And some of those that are zero deficiency alleles impact the expression of some novel alleles or novel variants. How do you, any thoughts on that we can?
yeah, I have all the answers. So it was interesting that on the one hand, the advisory committee suggested in their rejection after we had the second nomination is that they said, well, maybe the late onset are actually the ones that should get treated. And then they made the recommendation to not identify them. So again, it is a recommendation. I think since you have that now, the 5-year report, I think one, again, needs to publish. If you have fellows, they might be happy to publish even a case report. And there are mechanisms with the online journals or report journals that allow you to get those out in the literature. I think it's, I mean, New York, Joanne just showed us a picture of 2 twins in New York that had psychosine of 7, who seemed to be just fine. And after they got a transplant at 14 months or so, 16 months. So yeah, again, I look at the recommendation as this is the core condition and you can have secondary targets. So to me now, late onset is a secondary target, which also makes it easier for states because you get out of that presumed requirement that you have to identify everything, because you say, yeah, we're targeting the infantile. We get them all based on the literature. And if we use a cutoff of 2, we get most of the late infantile and late onset cases. But yeah, there might be very, very few that we're missing. But again, that is not illegal. That is the recommendation. We're actually doing more than what is recommended, and be happy with it. But again, make it apparent on your websites or through materials that this is what you do, so that you don't have to backtrack later and say, well, but this is what we decided, and you have nowhere to go and show them that it was actually done. So be transparent about those decisions.
I was just going to go back to what she said about needing the 2 separate assays. I think that's actually not, I think that's in many ways logical, both for legal and ethical reasons. I know in the Netherlands, they are only allowed to check boys for ALD, and it was considered not ethical to test the girls and then only test those that tested positive to find out if they were female or male. Instead, they had to test everyone to split it out, because I think the thought is you don't want to have information that could be important for someone's health and then not be sharing it. So I think there is a logical reason for that approach beyond politicians. Probably why it's logical. I think it's more a legal and ethical kind of.
Yeah, I think it's purely legal. If you had to choose how to run your lab, you probably wouldn't have done it.
From a data system level, it is very difficult because our system is looking for a baby to have been tested for everything. So we have to have all of these things in place to kind of allow the system to report out samples without Krabbe. And for example, when we added, I think it was whatever, Duchenne recently, we had to keep keeping it, we had to keep going back to our logic for Krabbe by when we're adding another disease, because everything is affected by having that built into our data system. There is the ability, so interestingly, we were using a lab developed assay, and we're going to start using the Revity kit that does NBS 1 and Krabbe and Pompe, but it also does Gaucher and Fabry and Niemann-Pick. But we don't report out we are not mandated to test those last 3. Now, our legal this time has said it's okay for you to run those assays, and just the data stays at the testing level, the mass spec, instead of transferring it into our data system. So for that, because there's not a parent refusal, they said that's okay. It's the parent refusal is why we have to do Krabbe differently.
Thank you. Yeah, the Dutch have an interesting approach. Very expensive. Yeah. Yeah. Any other questions?
We have about 5 minutes left. So I was wondering, a few questions on this screen, if anybody felt like they were able to see the future and comment on what you think states who aren't currently screening, for those who are not bound by the RUSP or those who have to follow the RUSP, what states may be doing in the future?
Well, do we have anyone from California? Welcome. Do you know what California is going to do?
I don't know too much, but I know that they're working on figuring out the algorithm. But I think probably within the next in the near future, it's going to be Crabbe will be on the list.
And I think California has a strong advisory committee that is not shy in voicing opinions. So I assume they will look at the evidence and make the decision based on that.
Yes. Yeah, just a comment, thinking about all the different states that are not involved yet. It just sounds like a really arduous process in the next couple of years, and just wondering, wow, with this country being a United States, wouldn't it be nice if there were just one lab that just did everything?
That's a lot of babies. So 3.6 million babies right now every year. I wouldn't want to do that. And you need redundancy. We have these weather events where sometimes labs close because because they're basically underwater, or the mail doesn't arrive or cannot be delivered, which, however, is a different issue. But yeah, I don't think we need as many labs as we have. And as I've shown, when Iowa starts, it means that there are 3 other states that get their screen as well, because you have this regionalization. Which ones?
Like New Hampshire doesn't screen for Crabbe, not.
Yeah, so
each state has to make a decision, even if Iowa does it.
Yeah, from what I understand regarding Iowa, that
Oh,
the
it's
other
pretty-
states will do that. So
Okay.
so the states still have their own decision-making power as to what they want. But usually there's not a huge difference. I don't know, from Revity's perspective, you do several states. Is it an issue that everyone wants something else?
No, no, it's not an issue. But it actually becomes easy for the lab to keep it quite common for all of them, instead of like doing a special request for each state.
Well, it's not on the RUSP yet. Oh, it was not on the RUSP yet. So again, the state will decide. And I think this is where, as stakeholders, we need to reach out and see how the decision is made at the state level, and then see whether you can educate them or provide them with the information so that they can educate themselves if they feel like it. We're not done, apparently. There's a bunch of states that have to follow, but I think it's going to happen. If you look at the evolution of the RUSP, once it was created, the states came around, but the last few conditions were difficult. NPS 2 was difficult because it was not just an add-on to an existing assay. I think that is very different with Krabbe disease, where, again, if you do mass spec and you don't have laws where you feel like you have to keep it separate, which I think only Ohio has, and is overcoming it, I think it's an easy implementation. Minnesota implemented within 8 months of adding it to the Minnesota panel because they were already screening for Pompey and MPS 1. So they just basically opened it up, looked at the GALC results for the next few months, did comparisons with other laboratories, set their cutoff for GALC when they have to send for cyclozine, set that up, and they started. So it is possible. And unfortunately, we couldn't get Minnesota to come here and present their process of having this done. But I'm sure they will be at the APHL meeting this fall, where most of the screening laboratories will be present, and we'll hear about it. Margie?
Last question.
Thanks. I don't know if we have time to address this now, but if not now, maybe we can address it later. But while we have all these newborn screening lab representatives, can we go down the table and ask you the last question? What arrangements do you have with specialists and transplant centers, and what can we do as clinicians, as a advocacy group, as clinical experts? What can we do to facilitate your rolling out of Krabbe?
We have Dr. Kurtzberg on speed dial.
Well, as Dr. Paterno mentioned, we ran into an issue where University of Louisville was like, oh yeah, we're going to do transplants. That's fine. And then of course, the first positive baby we get, oh no, we changed our mind. We can't do that. And our follow-up people that we refer things out to were not aware of that. So then they were kind of scrambling. So from a follow-up perspective, just having good plans in place and communicating that back to the lab and to the people that are in the process. Because we don't necessarily always, when we refer out to a follow-up coordinator, not necessarily to the clinician. So the follow-up coordinator may have one set of guidelines that they're supposed to follow, but like in our case, that had changed and nobody had let her know. So just kind of open communication. I think that's the important part.
Well, one thing that helps lab is when we report out a case, we report it as presumptive positive. And if whoever the following up clinician, if I know everyone is busy, but if they can provide that information back to us, if it is truly positive, diagnosed as a true disorder, then that helps in various ways. Least of all is like setting up a cutoff.
We would like that too. Well, basically, we send out our, like I said, results out to follow up. But when we bring on a new disorder, we kind of like include that. So we include our follow-up team, we include the doctors, and we set up our process of how they'll handle any kind of abnormals.
So in Indiana, we have care teams that the lab reports to, and the care teams are contracted with the state. They have we're also small enough, so we just have one true metabolic center in Indianapolis. And so our relationship with them is any of the presumptive positives get sent, results get sent to them, and they're the quarterback for how reaching out to the baby's PCP, reaching out to the family as needed. In terms of time to transplant, we've not ever had that challenge since we haven't had an infantile. But I think our process and the follow-up pathways are there. It's just not been challenged.
In Missouri, we do have 2 transplant centers at our big children's hospitals. And I believe they work closely with Dr. Kurtzberg if they have questions or anything like that. So that seems to go, I think it's going really well. It seems to be. But I know early on when we first started Krabbe screening, since we were the second state to start, Dr. Escalar came out and spoke with our geneticist. I think that was a really informational thing for them, like to be able to just get some expert advice. And I think our Krabbe Council has a good opportunity to be able to do that, just, for states who are just starting to screen, to invite them to a council meeting or to have an expert to go speak and just provide some of that information so they have the background and they know the expectations for transplant and what they need to do to be ready.
Since we are not doing cytosine testing, the majority of our results end up being pseudo deficiencies. So when we have an abnormal, we contact our genetic centers or neurology centers, depending on the location. There are 8 regional centers throughout the state. But we also contact the pediatrician, and it is usually the pediatrician who does the initial clinical laboratory testing, and the children a lot of times don't see a specialist unless the GALC and cycosine are confirmed as abnormal in follow-up. Something else we do with our high-risk cases is, and Krabbe is considered those, is my team will make a call back to the pediatrician 3 days later and make sure that they actually have gotten hold of the family and gotten the testing started.
Yeah, so in New York, of course, we've had physicians are the physicians that see this Krabbe cases. I've seen them a long time, so they pretty much have an idea of exactly what to do. But anytime we have one of these cases, I will usually call them and let them know it's coming, and we kind of go through what's the latest stuff too. Like if there's now in New York, we actually have a transplant center where we didn't have somebody who'd done a lot before, so we feel like, you know, let them know about that, the options. So there's try to keep things moving and up to date in that way.
I kind of talked a little bit about our process and how I rolled it out in Georgia, but I think one of the things that Hunter's Hope can really do to help this move along nationally is partner with APHL and the New Steps program. This is where states are going to be going to get information and resources about what is Krabbe? What am I doing? There's a lot to think about outside of the assay, and for just teaching your team what this is and how to communicate that to pediatricians, how we're going to communicate that to families, how we're going to convey the urgency of this versus, you know, some hypothyroidism. It's okay. We'll figure it out. You know, we have to be able to identify that appropriately and convey what providers need to do effectively. And the New Steps program is uniquely positioned as a resource for states to go to and find these toolkits that they make. This is, I've already looked, they don't have one. There's one coming. But and to that point, not just Krabbe, but you know, we're talking about these other leukodystrophies. The wide world of newborn screening keeps cracking open more and more, and so we really need to be partnering with these central organizations to make sure that information is in good central locations. And I'm not trying to, you know, talk to you over here and you over here and you over here so I can get all the information I need, but that I can go to one reputable source and get what I need. And also it's a great resource for states because I can go to them and say, okay, great. Who's screening for this? Who has lots of experience? Great. I'm going to call Joe and talk to him. Like, what's your team been working with? What are your struggles? What are your barriers? How can I be prepared? So not only can you have the easy access online information, but also develop those one-on-one relationships that help us all be successful.
All right, thank you very much. I think the summary is openness, communication between each other, with others, reaching out to the state programs and see how can you help, and be open-minded and realize all of the little parts of the newborn screening system, which is just very complicated, from getting the parents educated to getting the blood spot, to getting the blood spot to the lab, to getting it through the lab, to getting the result out, to communicating that result to the provider, and then the provider to the family, and all this kind of stuff. There's a lot of steps, all can go wrong. Many will go wrong. It's just the way it goes, but all to happen and see how things can be improved. And yeah, it would be nice if we were all more united in how we do this damn newborn screening thing. So it's good to know that APHL, New Steps, all of these things are working on ways to improve it. And we all just need to hear about them at meetings like this. So thank you to all of you who came up to be panelists, and I'll hand it back to.
Great. Yeah. Thank you, Dr. Maternal, our outstanding state lab specialist, for contributing to this discussion and teaching. So round of applause for our panel.